Okay, so this is the last thing we're going to have before lunch. And so thanks everyone again for coming today, and we're really looking forward to another great session here. I wanted to also remind people, please, if you didn't hear it at the beginning, we have the business meeting at the end of the day, and that's not just for people who are already in ESAS. That's for anyone who's interested in getting involved, or if you just want to hear more. If you come to the business meeting, it doesn't obligate you to be in the business, right? But we definitely want people who are interested in being part of this. We want to give people a chance to network and show your stuff too. So I'm Kristen Schreiber, and I'm actually at Brigham and Women's Hospital, not UCSF, but I don't know, I was like, oh, did I get a new job? And I'm gonna, we've assembled a great group of speakers here. I'm gonna kind of introduce it a little bit and then introduce each of them as they come up. And what we're talking about is navigating and conducting pragmatic clinical trials and translational research. And this is an area that I think is just really interesting. A little bit of background about me. I'm a neuroscientist. I did do the traditional MD PhD and did kind of a transition into more clinically oriented research through a K23 mechanism once I got to Brigham. And then have had a chance to get this R35 grant, which a lot of people haven't heard of. If you want to check it out, it's a really nice mechanism. And that's kind of allowing me to branch out a little bit. And one of the things I've really been interested in is trying to get evidence from our everyday things that we do, doing pragmatic clinical trials and really moving things between the basic science and the clinical science. So that's kind of how I got interested in this, and then we put together and put our heads together and found a bunch of really awesome people. I'm going to introduce them individually, but Vafi Salmasi from Stanford and Hance Clarke from University of Toronto and Dan Low from Seattle Children's are all going to get at sort of different aspects of this. So let's see if the mouse works. Oh, yay. Okay. So I wanted to outline what are the challenges of doing research, which I think are going to come up in all of their talks. So the first challenge I see is control. So when we're kind of more towards the left side, we have a lot more control over biological systems. We can answer specific questions, and that's really great. And I actually do a little bit of quantitative sensory testing now, and we have a little bit of control over people, but obviously not as much. And as you move further over to the right, you have less and less control. What you do get is validity and probably generalizability. And there's always this tension between having control over the question and the experiment that you're doing and then how valid it's going to be. And I think, as we'll see today, as we get into the more pragmatic trials, while you have validity and generalizability, you don't have as much control, and that can be a real challenge. The second is confounding. So there's a reason why RCTs are so popular, because it takes care of a lot of the confounds that are there, and that's why they've been, the gold standard for so long. But what is much more typical, and there's a ton of evidence coming out of the space of okay, so I'm going to see my patient in the pre-op area. The nurse has a cup of pills for multimodal analgesia, and then, oh yeah, we're going to do a block, and they've actually just drunk this, magic carbohydrate, and we're going to quickly get them on their feet afterwards. And so these are the ERAS protocols that I think we're all seeing. They're wonderful, but they're incredibly confounded. You can't say which element of the ERAS protocol is really making a difference, right? And I think we have to just think about how do we organize the rollout of ERAS protocols, for example, so that we can get some evidence out of that. And then the last one is variability, and this is actually my favorite thing. So in animal systems or in molecular systems, you can decrease variability, and actually that's what I was always trying to do when I was doing animal experiments. But when I got into people, I'm like, wow, people are incredibly variable. And I do think that, especially in the area of pain, this variability in how people process pain actually may give us an opportunity to get into personalized medicine and say, how are people different? So, for example, this is pain after total knee arthroplasty that Chris Albrecht extracted from the chart, along with opioid consumption, which looks similarly variable. And we say, okay, who of these people are we studying? And maybe more importantly, like, how do we sort this evidence to tell us something about that? So something we've been doing is phenotyping. So we may not have a complete genetic understanding or readout, but we can look at differences between people ahead of time. And so if you do that, if you do a study, go ahead and look at your patients, look at the people, say, what are they like? So one of the things we did is looked at temporal summation of pain, just with the quick little pain test that we did in the pre-op area, and said, how much does their pain score go up over time? And that turned out to be predictive of both pain and opioid use after total knee. Another area of phenotyping is in psychological stuff. So you may have heard of catastrophizing. That's a tendency to turn any event into a catastrophe. We can measure pain catastrophizing. And so when we looked at pain after mastectomy and looked at pain at 2 weeks, we looked amongst the low catastrophizers and high catastrophizers, and what we saw is that the regional anesthetic that we did, so those who were high catastrophizing who didn't get a block had a lot more pain, but those who got a block did, in fact. And it wasn't as much of a difference for the low catastrophizers, and this was also true of opioid consumption. So I think using phenotyping could potentially get us a little bit out of that. I'm just going to end with this real-world example that came up at Brigham that I think is going to illustrate a lot of the things that these guys are going to talk about. So you've all heard of Exparel. So what happened was we had sort of a temporary opioid shortage, and so our OR pharmacist said, okay, you can use Exparel, and so our thoracic surgeons kind of switched to using liposomal rather than regular bupivacaine for their intercostal and wound infiltration. And the practice kind of continued then after the opioid shortage. So we said, hey, let's just go ahead and, looks like I'm stuck. Let's go ahead and take a look at that as a group and extract the data and see and try to answer this question, is liposomal bupivacaine actually better than regular bupivacaine? Because there's not a lot of studies out there and a lot of people are using this. So what we found, Okay, so on the right in each graph is Exparel, and on the left is plain bupivacaine. And so what we did, and this is morphine equivalents per hour in different time bins. So this is post-op day 0, 1, 2. We did see a decrease in opioid consumption amongst people who got Exparel, but only really on post-op day 0 and 1. But at the same time, and now this is going to line up right under it, hopefully, but not have color. So essentially, the people who had Exparel also had more pain during the same time. So this is an illustration of variability. First of all, you can see how variable the pain scores and opioid consumption is. Confounding, because we've got probably people who are not getting as much opioids are having more pain. Are those two things confounded? And then obviously we don't have control. This wasn't planned in advance. And so we couldn't randomize. And I think there's probably even some biases. Like once our nurses see the Exparel band, they're like, oh, you don't need opioids. And so anyhow, but of course we can't exactly prove that. So anyhow, so that's just a little illustration of some of the things that come up. I'm gonna now invite Vafi to come up and introduce him on the way. And so if we could have his talk loaded rather than mine. Okay, oh, perfect. Okay, so just by way of introduction, Vafi actually completed his medical training in Iran, and then, as I understand it, had some experience in both primary care and neurosurgery as well. And so he's done research fellowships at both Johns Hopkins and Cleveland Clinic, and then completed his anesthesia residency at the Cleveland Clinic before coming to Stanford to do a pain fellowship. He's currently a a postdoctoral scholar and clinical instructor at Stanford in anesthesia. And his input to this symposium is really vital in the sense that he is, in fact, formally studying epidemiology and pragmatic clinical trials. So, and also starting some important work in this space. So he's going to tell us a little bit more about what pragmatic trials are, contrast them with RCTs, and give some examples of his own research. So thanks.
Thank you very much for the kind introduction. So I'm probably the most junior in the whole panel of the speakers for today. What I'm going to do is that before starting, I want to know how many of you have heard about the concept of pragmatic research and pragmatic clinical trials? And how many of you think that you know exactly what it means? Okay. Okay, so that makes my job easier. So we are talking about the translational research, and this is the model that when I was in medical school, I knew about the translational research. You bring a very cool question from the bedside back to the bench. You talk about the mechanistic way that how it works. Find some targets, find a drug or a small molecule to target that target, and then take it to in vitro and in vivo model, and after that back to the clinic, from bench back to the bedside. But as we heard earlier today, our job is not done there yet. As scientists, we all want to make medicine safer and better for our patients. So just finding an answer is not enough. We need to make sure that we can implement that answer in the society to improve the well-being of our society. So that's why the research is not done there. The research needs to move from T0 and T1 that we just talked about to T2, T3, T4, basically going to the patients in your clinic, in your OR. After that, going to the different practices that can replicate what you are doing. And after that, from the whole community, and see how it is going to work in an underserved country. So this is a very important concept that we are not stuck with T0 and 1 anymore. The next thing is that that's why generalizability and external validity is very important. So you need to make sure that what works in highly experimental setting of your clinical trial also works in the setting of actual patient care. Some examples. So this is very typical chronic pain clinical trial. 35 patients, really good number. They started with about 550 patients to just find these 35 enrollments. So less than 10%. Who knows about this clinical trial? Exactly, so probably the pain people in the room. I'm not going into details of the clinical aspect of that. This is a very important clinical trial in neuromodulation that revolutionized really the field. It's a very important clinical trial that was the 1-year and 2-year follow-up of that was published in Anesthesiology and Neurosurgery, 2 really top-tier journals. But look at the exclusion criteria. Any patient with psychological or psychiatric comorbidity. That's probably about 100% of patients that I see. So that's why I'm doing a quick detour to field of psychiatry. This is from a psychiatrist at Stanford, Dr. Humphreys. He looked at a bunch of different disease states in psychiatry and trying to look at what percentage of the people with these diagnoses are excluded from clinical trials. This is his first paper in schizophrenia. So anywhere between 55 to 95% of patients with schizophrenia are excluded from clinical trials that try to find treatment for schizophrenia. So we try to find these 10% at the top in explanatory clinical trials. We find an answer for that. And then from there, we take it to extrapolate that data to the rest 90%. So that's why I think it is not enough to stay there. It is enough to move it forward to T2 research, comparative effectiveness trials, large simple trials, pragmatic research. I'm giving you 2 examples. The majority here are anesthesiologists, so I'm going to just work specifically on anesthesia literature. I did my residence at Cleveland Clinic. I'm indebted to this brilliant group. They did 2 very interesting trials. The first one, they in colorectal surgery ORs, they left only 1 vaporizer over there. So as an anesthesiologist, your choice was either isoflurane or sevoflurane for a period of 2 weeks, and you could not change that. So they continued doing that with random blocks of time every 2 weeks. And then they did not talk to the patients, they did not consent the patients, they did not even see the patients. And then after that, they collected the medical record data for PACU length of stay, for hospital length of stay, readmission, morbidity, mortality, and they published many papers from that specific design. So, and they answer some really important questions. The second one, the same thing, instead of volatile anesthetic, they randomized to high FiO2 versus low FiO2 instead of blocks of time to blocks of different ORs, again, colorectal surgery. So these are purely pragmatic clinical trials. So in this table, there is a line between pragmatic clinical trials and explanatory clinical trials. But in reality, there is none. There is a spectrum in between. You can have a pure pragmatic clinical trial like what I just mentioned, but on the other hand, there's a lot of just in between these two things. So the pragmatic clinical trial, as you just noticed, is all inclusive. You try to include every single patient that goes to a colorectal surgery OR. You want to have a flexible thing. You want to have, your intervention is delivering anesthesia with either isoflurane or sevoflurane as a volatile anesthetic. You are not trying to just limit anything else, and you want all your anesthesiologists to deliver that. But in an experimental clinical trial, you want to have some specific just parameters for the entitle, some specific parameters for BIS number, some specific parameters for just a lot of other things that you do for that patient during the anesthesia delivery. And that's why you want the most just experienced people to do that, to decrease the variability between one patient to the other one. And then your control in explanatory clinical trials is usually very limited and defined as well. A lot of time it is placebo, whereas in pragmatic clinical trials, it's usual care. That's another can of worm that is about a complete lecture. What does usual care mean? But the other thing is that you want, in a pragmatic trial, as much as possible to record something objectively without interacting with the patients. And you don't want any follow-up, you don't want any just strategy to improve compliance, and you want to ideally include every single patient that comes in the door in your final analysis. That's the target, that's the goal. So these are some key differences between pragmatic clinical trials and explanatory clinical trials, but as extremes. And as I mentioned, there is a huge overlap in between. Because they answer a different, but at the same time similar question. The explanatory clinical trials answer the question of efficacy. Does this work? Does this treatment work in a highly experimental setting? And then when you go to T2, when you go to pragmatic clinical trials, is it effective when you take it from that highly experimental setting back to your practice? Does it work at that point as well? So it is not easy. It is not simple. It needs a lot of just infrastructure. First of all, it needs to be a part of your medical practice. So you cannot do it separately in an experimental setting because you want to have it in your medical practice. And then you need an efficient EHR, not the current EHRs that we have that is purpose for billing. And the other thing is a receptive institutional culture. All of them are necessities for having successful pragmatic research. I'm blessed with this campus. And of course, being in a lab with Dr. Sean Mackey, who has developed Choir. Choir is a learning healthcare system that has been in place at Stanford since 2012. It started from pain management department, and now it is in many other clinics, many other medical centers across the country as well. So Choir is, as I mentioned, a dynamic learning healthcare system. Currently in our clinic, it includes a lot of NIH promise measures. And we use a computer algorithm to decrease the survey burden for about 70% with that. Choir imports the schedule of our clinic from Epic, and then it just sends an email or a text to the patients a few days before their appointment with us. The patients can open that link in that text or email and just start answering the questions like this. And as a physician, when I look at my schedule on that day, it looks like that. And a bunch of surveys for each patient when I click on that patient. And when I click on each survey, this is how it looks. It is going to give me some specific T-score for different measures that we have put in. Also some percentile to make it easier for a clinician to interpret. And some trajectories, again, for a clinician to visually see that and help with the clinical decision making. And we recently added the point of care randomization feature to that. And we are currently running 2 clinical trials with that. Both of them are comparative effectiveness, and we are trying to just do it as a part of the clinical care for our patients. One of them is 2 very commonly used antidepressant medications for treatment of pain. And the other one is 2 waveforms of spinal cord stimulation. So these are the ones that we are currently running. We have enrolled probably about 10% for the first one, and we are starting enrolling for the next one right now. And this is the randomization screen that we have. And we can even have a stratification based on different disease states if you want to add it to your protocol. And the allocation of the patient is going to be shown on top as well. So it's not easy, as I mentioned. There are definitely a lot of challenges in implementing this. One of the things, I'm going to divide them into two categories, the platform that we have and the regulatory aspects of it. So our platform is really dynamic. We can make changes within weeks to months compared to something like Epic that takes years to make changes. But still, it is not as fast as a REDCap survey that you make and you can just make changes overnight. The other thing is that it gives me some, this is of course specific to my platform at this point, our platform at this point, that it gives us some type of report that the patients that are enrolled, how they are doing. But it doesn't give me the information about the patients that we approached but did not get enrolled. So going to that screening phase, the consort figure, I cannot create that. I still need to keep an enrollment log somewhere else. So I'm trying to find out ways how to merge that again. The other thing is that if I want to collaborate with another investigator, they need to have Quire as well. We recently added the cloud version of Quire, so that makes it a little bit easier to just make that transfer. And the last but not the least, I think I put it at the last because I wanted to speak a little bit more about the patient-reported outcome only. You saw in my table that I mentioned in pragmatic clinical trials, we want to have objective measures. I have none in my patients. And I think it is a challenge, but at the same time, it's a strength. Because when a patient comes back to me in clinic, I talk about patient-reported outcomes. I ask my patient after a spinal cord stimulator trial that during that trial, how was their pain? How much better it was? How much more they could sleep? How much more they could walk? Was that a fun activity that they always wanted to do that and now they can do that? So these are the patient-reported outcome questions that I'm asking them. And it is important to ask them in research, the same way that you ask in the clinic. So I still have a big battle with the IRB. I I applied for the waiver of documentation of the consent, not the consent, for my first study. And I think I qualify for that based on the rules and the regulations that exist. But IRB thinks that since one of the medications is off-label, it does not. And the fact that I'm saying that my intervention is not the medication, my intervention is the randomization piece. It does not go anywhere. So it's an ongoing thing that we are trying to learn from each other as we are going forward. And this is a question and a challenge at the same time for me, that I want to learn that when it comes to just interacting with patients in a pragmatic research, rather than objectively and without having that encounter with them, if we encounter with them, if we consent them, if we let them know that they are in a research study, how are they going to change? How are the outcome is going to change? Is there going to be a Hawthorne effect just based on that? I don't know the answer to that. So that's why I'm still at the feasibility phase. I'm trying to learn. I'm trying to just build it up more and have more clinical trials up and running. And if I just prove that feasibility, I can just have multiple different clinical trials running at the same time. My big vision is that as a clinician, if I don't know if I need to send my patient to physical therapy first and then do a intraepithelial steroid injection or the reverse the order, instead of just making that randomly in my mind, I do a randomization and collect data. And if you just ask enough of these questions collectively as a group, hopefully we can have a lot of good answers in the next several years. And thank you very much.
So I think we'll try to do a group discussion at the end, and have questions. But thank you, Vafi. That was really interesting. So next we're going to hear from Hance Clarke. He's an associate professor in the Department of Anesthesiology and Pain Medicine at the University of Toronto. Currently the Director of Pain Services and the Pain Research Unit, as well as the Knowledge Translation Chair, which is a great title. I want that title, at the Toronto Centre for the Study of Pain. So he has received an early career award from the Canadian Pain Society and really has been recognized internationally for his research and also for his practical improvements to patient care. In addition to his many academic achievements, he's really played a leading role in educating the Canadian public about the opioid crisis as well as cannabis, and fostered a better public understanding of all those things. He's really a strong champion of evidence-based solutions. And he's going to give us some insights into some of the barriers to doing that he's encountered along the way, as well as maybe some of the opportunities in engaging local hospital and governmental agencies to do this research. So, Hance.
Thanks, Kirsten, and thank you for the invitation. Do I just left and right click here?
Yes.
Got it. Okay. Perfect. So thank you all for attending today and spending time with us. And so I'm a bit of a storyteller, so I'd like to take you through the next 15 minutes and tell you a few stories. And the first is, as anesthesiologists, as some of you that are pain physicians, you really need to be able to sell your story beyond this room. And what are those opportunities that come along, and how you actually go about engaging the outside world will be the key, I think, factors on top of the research you're doing to see whether or not your program survives and thrives. And so there's nothing that I'm going to be speaking about that has any really conflicts or anything to disclose. And this is what I plan to do in the next 15 minutes. So, there was an opportunity 5, 6, 7 years ago. I think we all know about the opioid crisis. We've heard about it ad nauseum. And there was an opportunity from an institutional perspective when patients came in for surgery that we were seeing these folks that were being ramped up on their opioids and sent out the door. And so we had some recent data in our province, 13 million people in Ontario, that 10% of all first starts from the surgeons that were occurring in our institution were sending out folks on well over 100 milligrams of opioids. And so the number in Ontario is about 275,000, so 10% of that on an annual basis were being sent out well over 100 milligrams. And so we all know the CDC guidelines land around 90, and so that was an issue, and that was kind of a niche that we identified, creating the teams. And the one thing is, when we start to see wins and we have opportunity to disseminate this into the real world, how do we actually link with our institutions? And we don't see enough anesthesiologists or pain physicians, for that matter, reaching out to the PR folks and saying, hey, here's what we're doing. Here's kind of what we want the world to know, just from a lay press standpoint. And then obviously we've moved into doing some pragmatic trials, and I'll take you through some of that as well. So I'm not going to spend too much time on this, but I can tell you that in 2015, when I stood up at the Canadian Pain Society and I said, we, by the way, are the #1 prescribers per capita of opioids, so we do beat the US in terms of milligrams per individual. The pain world wasn't that upset or concerned about it. They're like, we have great palliative care programs. There's a reason Canada's leaders. We're the best. And I said, maybe there's a bit of an issue there, and there are things we can optimize, and potentially this, this pain addiction spectrum isn't so far removed, because the pain world was, we have a pain, we treat pain, and addiction is just over in the corner. And I think 15% of the population, probably of the pain population, does struggle with some opioid use issues. And so when you see, so this name on the second point there, Mel Kahan, he's probably one of the top academic addiction docs in the country. And he said, no, I'm sorry, but when I see 1 in 4 of the individuals in my world, they were on an opioid for chronic non-cancer pain. And so I won't give them 25%, but about 15%. And so, this is one of my favorite slides, because you can see this is probably where Canada sat for the longest time. We cover all drugs, we cover all medications. And now with the policy changes that were unfolding, we're actually seeing the more building of safe injection sites, et cetera, because we've kind of closed this pipeline that was probably freely accessible. Overall, we've reduced our prescribing by about 10% across the country nationally, but our death toll continues to triple. So not such an easy knee-jerk reaction of just restricting opioid prescribing. 13 million individuals in the province, and I always hang my hat on this number. So in 2003, we had about 300 deaths in the province. In 2017, we're up at about 900 deaths on an annual basis. And this can be spun two ways. It can be said that 15% of there's a 15% increase over the last 15 years, and on an annual basis, that leads to where we're at. Or doctors are killing patients and prescribing too many opioids, and that's clearly the story that we get on a daily basis. And think about that 15% number, and think about 1.9 million people being prescribed an opioid on an annual basis just in our province, and that 900 individual number is in there is no real slowing of that steep rise in terms of mortality as we move forward. So what was the opportunity? And so, Kirsten asked me to kind of take you through how we built the program, and I always say, I'm a pain physician, but if you want me to sell you a story, I can sell you a story. And so the reason we created this program was to look at, the transition from acute to chronic pain. But in 2013, when we had some funding pools come about, and they were looking at how do you create specific programs for complex medical patients that are kind of spinning in the system. And so, what we do well for 85% of the population. And I think Vafi touched on it in terms of the people we study are typically the people we don't treat, okay? And so 15% of that population that we don't treat very well, we actually cause some harm to. And so how did we go about, developing a program for that 15% of the population? And the most important part was, in the context of the perioperative setting, if we can actually convince the ministry and convince our funders that, we can help kind of stop the spiral and, of course, sell them the story that they wanted to hear, which was, we have these opioid patients that we can help to kind of wean back to baseline, or those that are naive, like many of you potentially in this room, that come in and have an operation and have these neuropathic pain symptoms. And it does not have to be moderate to severe pain, just symptoms you can't get over from a cognitive dissonance standpoint, that you then get stuck in a spiral and don't continue back down that path. And so it was a pretty easy sell. If you want to look for a complex patient, as Vafi kind of pointed out, pick a pain patient. They've got morbidity, they've got the psychological sequelae that go along with their condition, et cetera, and they consume a ton of resources from a healthcare standpoint. And so that was kind of the sell. And we got some nice positive press. When we started the program, it was simply picking up patients in the post-op setting, and we've evolved beyond that. The first year was, like any business, trying to have the surgeons in the institution even understand what we were doing. And over the next 2 or 3 years, fast forward to today, our doors are bursting. We can't see enough volume, and the surgeons are continually referring their patients that are, coming back at their 2-month visit and asking for more opioids or talking about these symptoms that aren't going away for them. Just a snapshot of the folks that we work with. And again, these are the tough folks. 60% of them came in on an opioid with a chronic pain diagnosis. 60% of them, 65% had 3 or more major comorbidities. And I want you to raise your hand if any one of your programs or any one of your wards in an institution you work at has an average target length of stay of 10.5 days. And so, we started to look at this population of patients we were seeing, and that's where they landed, and everyone was scratching their head. No, I'm sorry, but if you look for that 15% of the population, this is how long they spend in hospital. They sit there, and they sit on your wards for a week and a half, 2 weeks, 3 weeks sometimes, before anybody actually intervenes. And so it was a pretty easy sell once you start to dig into your data and look at what we're doing from an institutional perspective. And it's not just our institution, it's every institution. And so this is just a slide to say, what are we actually doing in this clinic? Well, the easy part is the prescribing, the weaning, the introducing the neuropathic pain guidelines early on. And one of the best studies, I remember reading, it was 2003, an anesthesiologist by the name of Chris Hayes in Australia. All he did was he walked around his acute pain service and asked people, do you have neuropathic pain? Do you have electric shock-like shooting symptoms going down your legs? If they said yes, they had a 70% chance of having pain disability 7 months after that question, okay? So we can pick them up while they're sitting in our institution. We just don't spend enough time kind of taking a look at these individuals, and I don't need to say too much about that. I think we have the cannabis boom in Canada, and we moved that up various years ago. So what did we do over the past 5 years? We've shown a reduction in hospital stay. We've reduced length of stay by about 3 days. When we looked at our last data, we have a clear psychological program associated with this. We do the easy part. The psychologists do all the heavy lifting. And, I always say when you build something and you open the door, you never know where it's going to lead you. And so what happened was the other parts of the hospital saw what we were doing in the perioperative space and said, wait, we need some help with that. What do we do with our IV drug users that we know have problems when they come in and we have no way to move these people forward? And what about Suboxone and buprenorphine and all these things? So the institution just gave us a first dedicated role for a pain and addiction NP that comes in under our auspices because of this. And who knew we were going to land there, but that's where we certainly are. I'm just going to give you one story, and this is where the integrating into the PR and starting to have the stories being put out by your whoever your local PR is for your institution. So this is a gentleman, very unfortunate story. His pain regimen after 13 years of multiple surgeries became 30 milligrams of hydromorphone injected sub-Q, and that was his regimen. Okay. he had asked for help in the institution, and many docs said, I can't help you, you've got problems. And they sent him out to the community to a local methadone clinic, and that clinic actually referred back to us within the institution and said, no, you guys have this transitional pain program now I've heard about, maybe you should see him. And so he's a pretty angry guy, and I'm going to play his video for you because I want you to kind of see the evolution, and I'm just going to say a few words as to how this really started to move things forward. You'll see some other YouTube videos if you Google us, and that was a lot of what our PR folks were doing for us. So I don't know if you can play this in the back of the room for me there.
I was prescribed opioids, in my case hydromorphone, self-injected, because I was in chronic pain following multiple surgeries over the course of the last 12 years. No, I'm not a junkie on the street. I get my prescriptions legitimately. However, over the course of the years, I realized that hydromorphone was not treating my pain. All it was doing was dulling my life and making it very, very difficult both for me and my family. I needed a different way to manage my pain. I needed to find a different solution to my problem because I wanted to rejoin society in a normal way and not have everything fuzzed over. I know that I will never be able to get rid of my pain entirely, but if I can manage it, I can continue living properly.
And so his real point of change was when his children said to him, we can't bring our grandchildren over to see you because you're injecting yourself too often. And so he's now actually one of the big champions. And we all have these champions in our programs, and how you get your message of your champions out to the world is really, I think, one of the key. Can we advance the slide? I'm stuck here. It's not moving forward. Okay, this is fine. So, what we started to do is, implement a lot more buprenorphine and naloxone and Suboxone, et cetera. But, the sad part was, how do we get people to a state of change? And, we look at our GPs and we say, you put them on these high doses, how do you bring people back? And so 30 to 40 weeks before some of these folks actually engage. And what I often say is, how are you going to get that type of resource unless you're in a multidisciplinary kind of pain clinic? And so, these are some of the things that we started to just put out there and put into the literature. And we published about, I think, 13 or 14 articles in the first 4. And so this is some of the pragmatic data that we're kind of talking about. And all we did was we took a look at a cohort of our patients that we followed to about 6 months. And so we, there we go. If you take a look at all we did was compare our opioid naive to our opioid experienced patients. And what I can show you is that, as you would expect in a pain population, there are more women than there were men. There was a significant recreational drug use component to the patients, both in the opioid naive and the opioid experienced group. And so again, speaking to those high risk factors in that acute post-op setting, most of them were chronic pain, as you would hope, from an opioid experienced group, and pretty significant comorbidities overall. And so, what we found at the 6-month time point, and people get these numbers pretty, you have to think about them a bit closely, because if you walked into the institution on 0 milligrams, the patient that came to our service typically was walking out on 106 milligrams. So those are one of those patients that are sitting there struggling and trying to figure out, what's next, what happens then when they leave the hospital, and how many of those could we actually get back to baseline long term. If you're an opioid experienced individual, you clearly came in at about X. We sent you out on about 2X, which was the norm, sometimes 3X, depending on the scenario. And how many people were actually then able to wean off? And people are surprised by this, but these are the complex patients. And again, remember, 15% of your total population. So when you see this data and people talk about the perioperative setting and there is a massive opioid problem long term, just remember, if you're opioid naive and you walk in and have surgery, your risk of being on an opioid at the end of 1 year is actually less than 1%. And so here at this opioid naive group, about 50% were weaned off completely. But here's the number that I think we hang our hat on, and this is really where we got a lot of traction with our ministry, was that if you walked in to the institution on an opioid or having a pain problem, at the end of this, 1/4 of those patients were no longer consuming their opioid. And so we had a little signal in terms of who actually increased, so young males in particular are a big problem. And so what was the message here? And I think the message was, one, as an anesthesiologist, we can help win this game, because the number one predictor of those people not being able to wean off their opioids were the dose of the opioid that they walked out of the hospital on. And all of these things in terms of the opioid experience, we know the catastrophizing aspects, if you have more neuropathic pain, et cetera. So last couple slides here. This is something that we were close. If I could do the PCORI application again, Beth Darnell at Stanford beat us out. And what we and what we were doing was, rolling it across. We had about 12 to 14 sites, and you can see the control. One site would be completely a control site, and then you roll in the service at each of these institutions. But our biggest, criticism, and it was a very fair criticism 4 years ago, was that, well, that's great, Dr. Clarke, you have this service at Toronto General Hospital, you have this great group of people, but these people haven't built it yet, and now they are. And so, there are lots of centers now in the US. I was just visiting Utah, and they have actually, in the VA system, they've created a beautiful kind of transitional pain service system with integrated EMR, et cetera, and it's pretty cool to see what's actually happening with this concept. This is what our trial looks like that's ongoing. So it was part of what we were going to pitch for PCORI, but we're actually now running it in Ontario as a 5-site trial. We got a couple $1 million from the ministry to do so. And, typical visits within the first 2 months, and then you follow these patients out. And again, it's all comers, right? So we do have some limitations in terms of your high opioid dose patients that we aren't taking everybody. But other than that, it's pretty wide open. So the Recoup trial, one of my colleagues, Kareem Lada, he's got a poster outside, but we are running the study at 5 sites. Of course, we were just told with the new government change that they're going to pull our funding, so we're working on trying to figure it out. But, academic medicine is resilience, and just remember that, balls fall against you more than they fall for you, and it really is just an exercise of tenacity. And thank you.
And lastly, actually, I'm going to let Dan get sort of set up here because he's a little more tech heavy. So thank you so much, Hance. It's really inspiring. I mean, obviously, the opioid crisis has been this huge thing in the U.S. as well. So lastly, we're going to have Dan Low, who is trained in the UK and is a pediatric anesthesiologist now at Seattle Children's, an associate professor there. And the cool thing that Dan brings to us, and we're just lucky to get him, is that I think he's a real innovator in data use and has created this, well, he's going to tell you all about it, created this company to really try to do, I think, what we would all love to do, which is sort of like Google the answer to our research question, sort of. But anyhow, thank you, Dan.
Thank you. Just going to upgrade the technology here. Well, thanks for having me, and thanks, Mike, for finding me at SPA. You good? Glitching. I'm going to talk about how to use real-world data. Is everyone familiar with that term? Real-world data, well, you all generate it. So every time you click a mouse, every time you hit a keystroke, every time you're interfacing with your EMR, every time you record a blood pressure automatically, that's real-world healthcare data that's collected as part and parcel of just giving care. It's not collected for a trial. It's just, and we have a wealth of that data now. It's generated by your phone, by your Fitbit, by the EMR, lots of devices. Who knows what this is? It's a black hole. This is Messier 87. It's 55 million light years away. The black bits, this is a little factoid for you, a little deviation, is the size of that black hole in the middle is the size of Neptune's orbit around our sun. Just think about that for a sec. That means Neptune takes 264 years to orbit our sun. That's how big it is. If Earth got sucked in through the event horizon, you should take some Dramamine and some ondansetron. You'd whiz around in 5 minutes. I mean, it's pretty crazy. The reason I'm showing this, it took 8 observation stations collecting 1 petabyte of data. That's 1 million gigabytes each. I can just do this. You good? No, okay. and it took 8 observation stations to collect that data. The reason I show it, getting healthcare data out of an did I say epic? Sorry, an EMR is, that's a total misspeak. Getting healthcare data out of the EMR is easier than photographing this. So this is we can do it, okay? We have 100% digitization of data now in the US in hospitals. When I arrived here in 2010, it was nowhere near that, but in the last 9 years, we've kind of tracked close to getting to 100%. Did you know, another random factoid, if we had an asteroid hit Earth today and we all died, like mass extinction event, and aliens came in 1,000 years, they would drill a core, and find out who lived here, there's no life anymore, and they'd find this layer of digital dust, and it would be in 2018, 2019. 90% of the world's digital data has been created in the last 48 months. That is nuts, right? Think about that for a sec. This is the problem. As a clinician, I'm just an anesthesiologist these days. I take care of maybe 1,000 patients a year, give or take, and I could not, say, past tense actually, get access to the data that I generate. Once that lap appy is off the table, I have to work really hard to find out what their pain score was in PACU, and I have to find really hard how long they stayed in hospital. And to try and find the last 10 lap appies is impossible. There's no mechanism to easily retrieve that data. And if the hospital makes me change protocols, remember the hat crisis? We had to change from surgical caps to bouffants. Did you guys have that in Canada? Yes. How do I distinguish a change from just a change versus actually an improvement? How do I, great, show me the control chart for surgical site infections and show me that dropping and I'll wear the silly hat. Okay. But if you don't show me that, I just feel like this is nothing against MBA people, but the MBA people on the C-suite are just pushing me around and making me do things randomly. It feels awful. And then who's familiar with this? In this room, who's tried to get data out of their EMR? Lots of people. Okay, how long did it take? What's the longest it took from you having a question to getting an answer? And never is an okay answer, okay? So how long was the longest time it took to get data back? Never? Infinity. Give us some other, what's more typical? If you ask a question today and you pick up the phone to your data analyst or you put a ticket into knowledge management at your hospitals, how many minutes, days, weeks, months it would take? Give me 6 months. Oh my gosh, right? That's pretty typical. I was at the IHI, and that's 5 to 6 months is pretty typical. Did you know, I was helping my daughter, she's 10, and 2 years ago, she was doing a history project. This is ad-libbing on the side, just got an extra minute. And I was helping her write her history paper, and she was in 4th grade, I think, and she was writing about the Pilgrims the colonies in Virginia in 1670. And she goes, Daddy, did you know how long it took if they had to send a message to England, like a really important message, like, we have no food, all right? Okay, if a ship was leaving Virginia that day and you had favorable winds, it would take 2 months to get to England and another couple of days to get up the River Thames. And if there was a horse waiting at the boat when it arrived to ride to the king to say, we have no food, and another horse to come back, it'll say, give or take 2 days, and you had a ship waiting to go, it would take another 2.5 months, so maybe 5 months to get a message back saying, we're on it. I mean, there's no food, but someone will say, we're on it, okay? How come I can see my data warehouse from my office? How come I have to wait 6 months to get data back in 2019? That makes no sense to me. Yes. So 3 years ago, I had this crazy idea that I wrote on the back of a Starbucks napkin. If you Google MD Metrics, that's the name of my company. Oh, I should say, I have a conflict of interest. I totally forgot. I'm so sorry. I'm the founder of MD Metrics. I'm the chief medical officer. I don't get a salary because we don't make any money yet. This is my crazy idea. Would it be crazy to suggest that if I was a physician, I could Google the EMR data? And then I could ask it a question, can you surface the last 300 ear tubes I've done and show me if their pain scores have got better because we started a new protocol 3 months ago? Would that be too much to ask? And could I get an answer back in 2 minutes? And they said, no, that's impossible. What do you mean it's simple? Okay, so we went and built it. So before we do that, I was going to talk to you about this guy. This guy was pretty influential. His name's Walter Shewhart. Everyone's heard of Deming because everyone goes to the IHI, so they all talk about Deming as grandfather of industrial engineering. Walter Shewhart actually figured it out in 1932. He was a Bell engineer, and he figured out to get data contains signal and noise, and the key to get information out is separate that noise from that signal. If you can do that, you can get the knowledge from the data. So what noise and signal? Like, what's this? It's the night sky. It's Orion. Some said Orion. So some people can see Orion, some people can't. There's lots of noise there, but there's lots of stars, okay? And I apologize, it's flashing. If I showed you that, okay, now you can see the signal. You can separate the signal and the noise. What's this? This is a control chart. It's the same. So once you can understand that a control chart shows your data over time, most of the posters out there, most of the studies people show on slides, they'll have a before and after, A versus B. They'll show you confidence intervals, and you're looking at, oh, that's better than that. I must do that. Depends if you're Bayesian or not, but you might change your practice, you might not. Depends what your prior is. We can talk about statistics afterwards. This is way more honest. It says, I have a control chart, this is what my baseline is, and this is what a metric is. It's like 30% of success, right? And you can go, and suddenly you have an intervention, you can see there's a change, something's changed in the system, okay? So you have a new mean, the control limits are set pretty broad, so the upper and lower control limits are set at 3 sigma, that's 3 estimates of standard deviation, so you can see that the system's changed, and no one would argue with you that the system has changed from that implementation. Well, if you can take the EHR data and put it all into control charts on specific populations after specific interventions, maybe you can figure out if a protocol works or doesn't work. Maybe, right? So this is a study from friends of mine. They were looking at Sugammadex, which came out a few years ago in our hospital, and they said, I want to know, but no one studies Sugammadex in infants, so I want to know, can we look at all the EHR data and find out all the infants that had Sugammadex and those that got neostigmine, and then look at, as an outcome metric, how long it took to emerge, end of surgery to out of room time. That took Amber 1 year to do that. I'm going to show you how to do it in 60 seconds, okay, hopefully. Now, the people who coach me on this say, don't ever do a live demonstration of software over the internet at a conference. That is the most insane thing to do because things can drop out, okay? So let me see if this works. Sugammadex. We're going to do a Sugammadex study. Let me just, oh my gosh, all right. Hey, tech people at the back, how do I turn mirroring on my Mac quickly? You can go to settings. Okay. Settings. The settings, display, and then mirror, arrangement. Mirror, you got it. Oh my gosh. Okay, I owe you a beer. Who said that? Thank you. What's your name? Sam, thank you. I really appreciate you. So I'm going to bring up a new, we're going to do a Sugammadex study right now for you. We're going to go into the Anesthesia data cube. We're going to put my name in, and we're going to go Sugammadex versus neostigmine, S versus N, as for an aim statement. So now it asks me to log in because I've spent too much time fiddling with my computer. This is why you should never do, Steve Jobs never did this. It was all canned, right? So let me just try that again. All right. Sugammadex versus neostigmine, and we want to know, we're going to anesthesia, Dan, and S versus N. All right, in infants. So what we're going to do, I'm going to enlarge that for you. I'm going to build a cohort. This is live data from straight out of Seattle Children's Warehouse. It's got to go over 2 firewalls and hotel Wi-Fi. So let's have a look. Neostigmine. But maybe I can get back faster than 6 months. So let's grab, I don't know, let's grab 3 years of data, 2015, and we'll go through to 5/1/2019, and I'll just grab the main surgery patients. And I found 55,000 patients. Great. Of those, let's find all the under 29,000 during those date range. If I look at the patient demographics, you all recognize, you and your nurses all put this data in every time. So let's look at all the 2-year-olds and under, and then we'll go, okay, how many patients can we find? 6,800. Okay, let's clone that cohort, Before we do that, let's identify all the neostigmine patients. So let's search under drug admin. Can I find, of those 6,000, all the ones that got an interop dose of neostigmine? So, neostigmine. Okay, great. So we'll let that spin up. And how many neostigmine patients do we find under 2 who had surgery? 0. No. This is why you should never do a live demo in front of 734. Okay, oh my gosh, my CTO is going to kill me because he told me don't do that, just show recording. I said that's boring. But he's right? Sugamidex. How do you spell Sugamidex? 2 A's, right? 2 M's. Sugamidex. So we'll clone that cohort, and we'll just change our protocol for our second cohort, and we'll find all of the Sugamidex kids, okay? So bear with me, interop, Sugamidex. This took Amber a year to do this. So S for Sugamidex, and okay, here we go, Sugamidex. And how many Sugamidex patients do we find? 0. It can't be 0. 0 is not an 259. So now we're going to jump to analysis, and the measure she wanted was, what is the emergence time? So let's just circle emergence time. Here we go. And we're going to do, all right. Yes! All right, so that's my emergence time. That's really complicated. You can see about 2016, Sugamidex came to the hospital. That's really funky to look at because they're overlapping timelines. So once you have software, you can create a time machine, and the time machine can do this. Okay, ready? Whoa. I can separate the timelines. From an analysis point of view, I don't really care if you had overlapping timelines. I can now separate them as a cohort, as a before and after study now. So now I can see that my emergence times was about 18 and a half minutes, and it was about 17.6 minutes. So someone's going to say, what's the p-value? I don't care what the p-value is. Who saw Regina's talk yesterday? Death of statistical significance. So these look about the same. You say, why are the dotted lines varying so much? That's because the subgroups are different. So this group only had 34 patients in. This one had 48. So your control limits will vary based on your subgroup size. If you want to get super technical with me and say, look, I want to know if there's any signals, just like Orion, I can do this. I can extend the mean from the neostigmine group, and suddenly, yes, okay, the blue line becomes a dotted line, and you can see that the orange dots are equally distributed. You can eyeball it, and the AI says there's no signals found. We're good. Neostigmine Sugamidex for an unblinded, uncontrolled time series data for 2-year-olds in our institution that get out the OR the same time, okay? So that's a quick run-through of what we can do with data. So we answered that. That wasn't 1 minute. That was more like 3. I'm sorry. Okay. So we've operationalized this. We did the same. We had the same opioid shortage in 2018, and our CMO said, hey, can you guys, because you guys use so much opiate in your OR, you guys are crazy, can you come up with strategies of multimodal, and can you really try hard the next 3 months not to use so much opiate? Okay, so we said, okay, let's take our tonsillectomy group. There's 1,200 patients. So we went to the literature. We found Chris Glover's paper from Texas Children's from 9 years ago. He studied a 4-arm study, 30 kids or so in each arm, and he found that dexmedetomidine is equivalent to 0.1 of morphine in 30 kids in Texas Children's from 9 years ago. We go, hey, that's evidence-based medicine. Let's do that. And so we did it, and we did it for 500 patients, and we looked at it in real time. And these are our results. Our pain scores were about the same as when we were giving morphine. Our POV rate went down about 80%. Rescue morphine, when you don't give kids morphine interop, they need less morphine post-op. Crazy, huh? It's 19% morphine rescue rate, but we did extend our length of stay by 7 minutes. We just published that in Pediatric Anesthesia on Friday. That got accepted. So for those scholars who want to do scholarly activity to get promoted, this kind of research that takes about 3 minutes to pull up a query is really fast. So that just got published in Pediatric Anesthesia. Then we started rolling it out across our whole surgery center. We do 4,000 patients a year. We said, well, if it works for a tonsillectomy, why wouldn't it work for a hypospadias? And why wouldn't it work for an ACL? And why wouldn't it work for anything else? So we copied our tonsillectomy protocol in terms of the interop, analgesia, and we started switching it out. This is our chart of interop opioid use over the last 14 months. We used 170 vials of fentanyl a month, 100 vials of morphine a month, and 20. We're now down at 0, and last month we used 1 vial of fentanyl for 450 kids. Then you go, oh my gosh, that's crazy. Your kids must be going berserk in the PACU. No. This is our PACU data for 9,000 patients, 2017. 2018 is when we started switching out our drugs. Our ENT population represents 1/4 of our cases, so that has a disproportionate effect. Here we go, we switched out morphine, we were learning how to use dexmedetomidine, we got it dialed in, so our pain scores are kind of now at the same level as they were before we did all this work. You can see the rescue morphine rate in PACU has hit an all-time low. There's actually a signal there. You've breached your 3 sigma limit. In 5 years, we've never breached our 3 sigma limit. We're down at a 3% morphine rescue rate when we stopped giving opiates intra-op. And then our discharge times across the board are the same, and our PONV rate last month hit 0 for the first time in 5 years. So this is what you can do with pragmatic data. You can do very quick, like I know in a day, was today's hyperspadias any better than the last 3 years? You can see instantly when you change a protocol, and this is what the EMR should be able to do. Thank you very much.
All right, thank you so much, and that's quite impressive that you pulled that off. So I think we're getting close to lunch, but it would be nice to, if anyone wants to ask any questions to any of the panelists, or looks like we've got a customer. And please, yeah, say who you are and where you're from.
Hi, Andrew Suin from Halifax, Nova Scotia. Question for Dan. Brilliant data, brilliant software that you're using. Is there any way for implementing that into actual departments and having the granularity to look at individual staff and how they function? And is that going to be detrimental as far as being punitive, potentially?
Thank you. I can hit one button and I can stack rank everybody and put you on a funnel chart, and I can show you if you're inside the circle of trust. So basically what it will do is create a funnel plot. If you catch me afterwards, I'll show you. It takes about 5 seconds. So you can take those same 9,000 patients and you can stratify it by the 9 anesthesiologists. And you can say the person that does the most cases will be in the far right, the person who does the least is on the far left. So that creates an actual funnel for your control limits. You can do that by surgeon, nurse anesthetist, anesthesiologists. Does it cause harm? No, it doesn't. People are naturally competitive. We've had it open. This has been, we believe, we took a very brave step at Seattle Children's. Let's democratize the data. Right now, you should be able to open any chart in your institution at Nova Scotia under the guise of QI, right? Chart review QI. All we've done is we've enabled you to open 9,000 charts in 5 seconds. I mean, it's conceptually no different. We've just taken the manual step out of it. It's always been that way. It's always been an open book. We've just made it really open.
So Dan, could I just like follow up and say, obviously, so everyone in the room is like, oh, how do I do this? In terms of using different electronic medical record systems that are out there, what are the connectivity issues? Like, can you do it for any medical? And we talked about
so the way this was engineered, when we started working on this 3 years ago, we didn't want to build an in-hospital, this will only work in one hospital. It's been designed so it'll basically sit on top of anyone's EDW. So we worked with hospitals that have got Epic, with Cerner, with McKesson's, old Centricity. So we can work with anyone's data warehouse. We can work with Clarity. We can work with Cerner's homegrown warehouse. Data is just data. Once you get it out of the EHR, which is trapped in 1990s architecture. So I don't know if you guys know this, the data in your warehouse in your EHRs is a flat hierarchical database, which means that one piece of data has a relationship with just one other piece of data. Once you take it out of that format and bring it into this century, so you fast forward 30 years, you can put it in a 3-dimensional cube, you can put it in the cloud, you can run it on a supercomputer, and you can do stuff like this with it. It's totally cool.
Very, very impressive. I guess my question is how do the EHR companies, how are they working with this, or is it just that they don't really have a say in it? Like, I guess that's what I don't understand is how, and even like there, I know there's no patient data being disclosed, but like obviously the issue always of patient privacy and different things. Like, how is that being, accounted for in this?
So everything you saw is totally HIPAA compliant. The EHR companies don't know about this yet. I'm trying to stay off their radar as long as I can before they.
Won't help you.
Okay, so nobody say anything.
So when we started, everyone said, why has Cerner and Epic not done this already? And the short answer is it's not in their business model. They're selling you a cash register. Has anyone in this room spent any time with a Cerner or Epic rep in the last 5 years? One? Okay, two. You must be very special because clinicians don't tend to be their customers. They're selling to the C-suite and they're selling to accounting. You know that the EHR is primarily a billing revenue machine, right? It's a cash register. And they're quite happy for it to be like that. And if I get on my soapbox, I'll get really angry. But they took $40 billion of federal money to push this onto hospitals. They promised lots of things. They've been saying for the last 5 years, oh, well, that's coming, and it hasn't materialized, and it's not in the roadmap. And I think it's up to innovators in our ecosystem to go, okay, let's make this work for us.
Hi, I'm Terry Vasilopoulos. I'm a biostatistician, and I was wondering, I love getting away from p-values. I was wondering how receptive it was. I saw that you got published, but did you have any pushback from the journal of publishing this type of data?
No, I think this is the first major publication that went through without using the phrase statistically significant, and it went through without a single p-value. So we described signals and noise. So all those control charts, it's just, imagine one of the first control charts, it's got variation, that's noise. We call that common cause variation. When you have a signal and it spikes, and that's called special cause variation. So when you surface two cohorts, the language we use is there was no special cause variation between the cohorts, and that was fine. That's it. I mean, it's very Bayesian. It's very kind of compelling. It's like okay, and it flew through review in 48 hours.
And I want to broaden that question out to our other panelists too, because this is another concern I've sort of had is like if the RCT is sort of the gold standard for publication and people, journals want specific designs, once you move into the pragmatic space, like how receptive are the journals to that? I mean, do you just have to have huge numbers? That's kind of what I've seen, but I wonder if the paradigm may be shifting.
I haven't been able to publish anything yet in the pain journals because I don't have any data yet, but I've been looking at a lot of just other specialties during my master's that I was trying to see what they are publishing. And I think it's a trend in a lot of other specialties and in the epidemiology in general that try to stay away from the statistical significance, the p-value, try to show the magnitude of the benefit for these patients. How far does the treatment work? And even if your number's small, you can still try to publish a preliminary data with that pragmatic clinical trial as long as your methodology is valid. But then you need to acknowledge those limitations, that this is a limited number. If I want to really make any inference, I need to do this, then this step. And I think now the whole epidemiology world is moving more towards finding ways for causal inference, not just saying that these two differences are statistically significant or not.
So, I wish Dan all the best in the crusade to get rid of p-values, but I can tell you, we're at the moment still locked in, and so I can show you all kinds of trending data and then try to put that into the literature without some type of, RCT. And that's kind of, well, that's great, but until you show us that there is a significant intervention here, we're not giving you any more money to do anything else, right?
And the reviewers are not always, quite as open-minded, perhaps. It just depends,
100%.
perhaps. But I do think that I have started to see some pragmatic research studies, even not big ones, but if they're addressing some really important question, and if you can frame it in an interesting way, and it's very close to actual clinical care and has high validity and high generalizability, maybe that can sort of compensate for the lack of control. But I don't know. I think it seems like it's sort of evolving.
I mean, if I can give you just an example of one of the biggest challenges right now is this whole cannabis world. And so everybody's, cannabis is utopia of society, and it's showing all these effects. And so we're trying to be creative in terms of, trials and how we look about this. And we're maybe thinking about some N of 1 with some Bayesian analyses and things like that, and try to sell that story, because the RCTs just doesn't make a lot of sense when you don't even know what product you're dealing with in the first place. So anyway, interesting.
Other question?
Yeah, fantastic. Thank you. I have a question. I'm very interested in numbers. So for pain measuring, for example, we can use VAS or other measures, but recently many people use morphine equivalent inside the hospital. I wanted to know if there's anything like that you would be able to use in clinic.
So you're saying the question is really when we extract information about how many morphine equivalents people are using
Yeah, as
in the
Vafi
hospital.
mentioned, finally for a pragmatic trial, we need numbers,
Yeah.
quantity. So I wanted to know if there is a measure to quantify the pain in clinic,
Right.
like as hospital by measuring morphine equivalent.
Right. Well, I mean, just as someone who studies pain a lot, there are a number of different ways beyond the numerical rating scale, looking at burden or functional disability that, depending on the time frame that you're looking at, can be more or less, I mean, you can sort of spread it out. If you're looking at a chronic pain condition, obviously, you can look at it over any number of time. You can look at trajectories, I mean, obviously, when you're in the hospital, that's when you're being treated with opioids, like say post-surgically. But I would imagine with chronic pain studies, you can do a similar thing in terms of looking at how much opioids people are taking, but just over a different time bin, if I'm understanding your question correctly.
I think so. Just I don't know how much we can, because pain is subjective, how much we can make it objective. I don't know, in clinic we can measure it the same as opioid that we could use in hospitals.
So the biggest issue with opioid consumption in the outpatient setting is the inherent bias from anybody reviewing your work is, well, that's fine, you write the prescription, so any change you show, well, it's somewhat influenced by the prescriber. So I've reviewed several papers by the family practice units in Canada, and they have these amazing tapering regimens, but in the small caption, well, if we find you with synthetic fentanyl or buying elsewhere, we rapidly taper you and kick you out of the program, well, your weaning rates are going to be 90%. And so, I think, and then the question is, so then, other than morphine equivalents, what do you study? And I think Kirsten's kind of hitting it on the head. I don't even ask people what their pain severity score is. I really don't care. And I ask them for their disability scores, and pain interference is kind of what we've started to move towards.
Yeah, we'd all love like this perfect objective measure of pain, but I think pain is by nature subjective, and so there has to be that element to measuring it always.
If you don't mind, I can add just one thing, is that we still have the impact guidelines about the reporting of different things that you gather in a clinical research. So that's one thing that you can go back. There are a lot of validated measures in pain. Of course, if you go back and look at the validation of them, you see that sometimes the validation is only 10 patients. So a lot of validation for these are really iffy. Promise measures have more extensive validation because they were, of course, sponsored by NIH. But the problem is that a lot of their validation is in general population. They are not in chronic pain population. But at least in our center, what we try to do is that, exactly as Hance mentioned, we do not stay only with the pain. We try to ask for function. We try to ask for the just psychological well-being of the patient. We try to ask for the social well-being of the patient. So a lot of these other promise measures in addition to the pain itself. So the big picture for that patient, not only one thing. Pain catastrophizing is another thing that is a predictive thing in a lot of just trajectories at this point.
So I think everybody's getting hungry probably, and if you have other questions, feel free to come up. But then also wanted to say, so actually, what's the schedule after lunch?
That's what I was just going to say.
Yes, okay.
All right. So the plan, so lunch is right outside the doors for everybody. Just come back in. That way we can sort of continue conversations. You can chat with people you may have heard from or colleagues that you haven't yet met. And then that goes till 1. And then there is the poster session until 2:30. And then we'll be reconvening for the last few sessions back here at 2:30.
and there will be more food. So come back. And then also there will be the business meeting where you can get involved.